Welcome, and thank you so much for attending this virtual webcast that we're doing right now regarding Alzheimer's disease, latest research, and prevention strategies. Obviously, Hoag Hospital is a phenomenal resource for the community here at Orange County, and we hold it in extreme presence that we need to parlay appropriate information to the individuals out in the community. So we thank you for attending this webcast and this virtual program. Because of COVID, we obviously have to limit things in person, but one nice way of doing things is to be able to bridge that divide through the virtual realm. So thank you for joining us. I'm Gus Alva. I am currently the medical director of ATP Clinical Research in Costa Mesa. I'm a diplomat of the American Board of Psychiatry and Neurology, and I'm also the director for the Senior Brain Health Program at Hoag Hospital's Neuroscience Institute. I also serve as an assistant professor at the University of California in Riverside, as well as the University of California in Irvine and Chapman University, which means I enjoy teaching. Part of the reason by which we're here tonight, we're going to be talking about the significance of recognizing and confirming an early diagnosis in a disease continuum, which specifically entails the cognitive domain. Our objectives tonight are going to be understanding what is oftentimes called the very earliest onset of Alzheimer's disease, and that would be mild cognitive impairment. We'll also take a look at how this, in the continuum of Alzheimer's disease, can create problems, which means that we're going to be reviewing the current definitions of Alzheimer's disease. Just by attending this program, you are fostering yourself with additional information and strengthening your educational base so as to be able to answer those pesky questions that friends might ask of you. Will everybody develop Alzheimer's disease? The answer to that is no. But there are certain people that are at higher risk. So we'll talk about current approaches for screening and diagnosing mild cognitive impairment due to Alzheimer's disease and mild Alzheimer's disease dementia. Why would we want to do that? Well, it's better to address something in a proactive manner than being reactive, which would be the case of someone trying to mimic an ostrich and hiding their head under the sand. We'll take a look at highlighting the rationale for detecting patients early in the Alzheimer's disease continuum, and we'll take a look at potential implications of earlier diagnosis for patients that will subsequently develop Alzheimer's disease and the healthcare system as it unfolds. First and foremost, let's take a look at what dementia entails. We oftentimes hear that term bandied about. Well, dementia can be a smattering of many different things. I'll give you an example. I had a patient that came in to see me just this past week. It turns out that she had all of the classic characteristics of Alzheimer's disease, but she did not have Alzheimer's disease. What she had was this scenario in which her hippocampal region had sclerosed and was creating problems for her. There are many types of dementia. Dementia simply means loss of short-term memory that may be associated with several different things. 65% of dementias happen to be Alzheimer's disease, but we clearly also see that individuals that may have had a stroke will subsequently potentially develop cognitive flaws. That's generally the scenario of vascular dementia or mixed dementias if we see some superimposed features of Alzheimer's. Patients with Parkinson's disease may develop dementia, and that would be called Parkinson's dementia. There's a variant of that called Lewy body dementia. So as you can see, there's a whole slew of different dementias, and truth be told, despite the fact that our diagnostic accuracy is quite good at the present time, after post-mortem tissue autopsy confirmation is done, which means you've died and now it's safe to actually cut a hole into your skull and scoop out some brain tissue to verify what exactly was at play. 50% of the cases that then subsequently get reviewed have an underlying mixed neuropathology. But let's take a look at an overview of Alzheimer's disease. If you'll note, this screen will show you a gross morphology of our brain. This mushy tissue, this matter that weighs about 3 pounds but is so critical for our functioning. You'll take a look next to this, a microscope. And you might think that I may have, because I'm so old, had first review of different types of tissue with this instrument. Truth be told is I did. Part of my training in medical school was utilizing an instrument like this, a microscope, to take a look at specific features. The pathognomonic features of Alzheimer's disease are nicely shown on the screen right here. What you'll note are amyloid plaques, which are a form of junk that accumulates in the brain that shouldn't be there, that chokes off different cells and causes them to die, and neurofibrillary tangles, which disrupt the overall cytoarchitecture of neurons, or the nerve cells that reside in our brain. If you take a look at what the problem is with amyloid plaques and neurofibrillary tangles, is that they are implicated with widespread neuronal degeneration. And if you take a look at the gross morphology of the brain, to the left you'll see a healthy brain, to the right you'll see a brain that's shrunken. But it's not only shrunken, there's an enlargement in the grooves that typically would be there with nice plump tissue surrounding it, those sulcal grooves that now become more pronounced, and the ventricles which become enlarged because of that loss of tissue. And if we were to take a look at the histopathology, meaning what we would look at under a microscope, we would find those darn plaques and tangles that are creating so many problems. Here you're seeing a very famous individual. This woman's name was August D. She was the very first patient that was described as having Alzheimer's disease, and this was done by this gentleman, a Bavarian psychiatrist by the name of Alois Alzheimer, and thus the term Alzheimer's dementia. It's an interesting history because at that particular point in time in the early 1900s, we're talking 1906, 1907, there were 3 reasons by which you might have memory decline. The first one would be tertiary syphilis, because we didn't have a way of curing syphilis at that point. And syphilis, left untreated, will reach a tertiary point which will eat up your brain. The second would be what's oftentimes still dubbed dementia precox, or schizophrenia. And the interesting thing with that scenario is that obviously there are different hallmarks associated with it. Now, what Alois Alzheimer did was to basically figure out that this woman that was, again, in her early 50s, was having a lot of psychotic symptoms, and associated with that was her memory decline. And interestingly enough, he took a look at a microscope, scooped out some brain tissue after she died, and found the pathognomonic features that we still talk about. But interestingly enough, a diagnosis of Alzheimer's disease has historically been one of exclusion. So as we assess someone and there's a clinical suspicion that there's a problem, we'll typically do some cognitive screening, which I want to take some minutes to speak of, because those of you in the community can readily avail yourselves to something that Hoag has at the disposal for everybody in our community, and that is the availability of a digital biomarker, which we'll speak about in a second, called the mild cognitive impairment screen. If that individual happens to have some sort of a positive flaw with cognitive screening, then generally the clinician would be reviewing a whole slew of different things. And some of the possible causes of cognitive problems could include utilizing the wrong medicines in combination, maybe having a poorly managed chronic illness like diabetes or high blood pressure, pseudodementia, which is basically another term for major depressive disorder and oftentimes affects many individuals. The person that can't hear or see appropriately might not necessarily be able to encode information appropriately. If there's an endocrinopathy like thyroid dysfunction or diabetes, which I mentioned earlier, that could lead to problems. The individual that has a vitamin deficiency, whether that be vitamin B or D even, anemia, some sort of an infectious issue that could lead towards a delirium. And there's a whole slew of other things that, as a clinician, most doctors would be able to work up readily. But like I said in the past, we would want to discard all of these things before we considered Alzheimer's disease. That has changed. Why has that changed? Well, it turns out that the underlying pathology of Alzheimer's disease, in an insidious, meaning a very slow, gradual, creepy manner, grabs hold in the brain. This is a problem that starts out in the primitive part of our brain, nucleus basalis of Maynard, and then subsequently migrates up out into the outer cortex, affecting the temporoparietal region of the brain, and then subsequently moving over towards the frontal region. Several studies done by some famous scientists, Sprack and Bragg, several years back, specifically took a look at the amyloid and the neurofibrillary tangle changes that ensue with brains of individuals affected with Alzheimer's disease. And we note that oftentimes a lot of the symptomatology that is being picked up could have potentially been picked up a lot sooner. Let's discuss how that might happen. First things first, the amyloid hypothesis at the present time is central to the underlying neuropathology of Alzheimer's disease. It turns out that genetically we carry certain genes that mom and dad gave us. And it turns out that there are certain genes that correlate with Alzheimer's disease, among them chromosome 21, chromosomes 1 and 14, which are the presenilins 1 and 2. And we basically note that with chromosome 21 coding for this particular genetic variant of the amyloid precursor protein, there's a cleavage on this protein that should be occurring. And when that cleavage is done the wrong way, it leads towards specific problems of this gunky form of beta amyloid, which lead towards neuronal demise or neurotoxicity, brain cell death. So we note that one of the big strategies at the present time has been trying to get rid of that, and we'll talk more about that in a second. Additional hypotheses for the underlying illness associated with Alzheimer's disease include the tangled neurons, right? So tauopathies and the hyperphosphorylation of tau. Well, those characteristics also, however, can lead us towards their discovery a lot sooner, which means that we can take a bad thing and turn it on its head. In other words, if we can detect these problems sooner rather than later, they may be utilized as sentinels, as landmarks that help us then figure out whether individuals will develop problems or not. It turns out there's a lot of different hypotheses that include, again, additional problems, whether it be mitochondrial dysfunction, whether it be the accumulation of inflammatory markers, whether it be additional issues tied in with structures of neurons and so on. But the important thing is that these two characteristics are at the forefront at the present time in what we try to do along the lines of discovering new treatments that might help us greatly. So let's review. The hallmarks of Alzheimer's disease include the neurodegeneration or the shrinkage of brain tissue. And we know that there are two characteristics associated with this, amyloid plaques and neurofibrillary tangles. We think that these may lead to neuronal loss. That has not been proven completely. But we think that the symptomatic correlate of dementia, meaning the loss of short-term memory, as well as functional decline and the onset of behavioral problems, could be attributed to neuronal loss, as is noted in this slide. Now, we talked about a continuum previously, and the Alzheimer's disease continuum is represented by multiple progressive stages. The very first two stages are preclinical, meaning there's no symptoms at all. Stage 3 is where problems first begin. That is mild cognitive impairment. And mild cognitive impairment looks like this. The individual that has subjective memory loss, but they're not necessarily having any type of functional problems that would be noteworthy. I'll give you an example. I had a patient of mine who was literally a rocket scientist. We oftentimes bandy about these terms, right? But this man literally was a rocket scientist. And his complaint to me was that he could no longer multiply 4x4 digits in his head. And I looked at him and I thought, that's the dumbest thing possible. I've never been able to do 4x4 digits. What are you talking about? What's the problem with that? Well, to him, that was a massive problem, because it meant for him, the very first index, that his cognitive ability wasn't exactly where it should be. Now, obviously, I just thought, wow, that's kind of odd, but okay, let's take a look at it and let's track it. And so what we notice, stage 4 is the earliest form of Alzheimer's disease. This is now where your short-term memory has gone by the wayside, and now you're starting to show deficits. The individual that previously was an architect and very meticulous about his craft, but now is forgetting of putting in specific things to his drawings that would be critical along the lines of the models that he's trying to create. Or the accountant that starts to flub up the tax returns, and now all of a sudden it might seem minor initially, but then subsequently becomes more progressive and more notable with time. Stage 5 is a moderate staging of dementia, where this is now quite apparent. The individual is now repeating themselves over and over, asking the same question over and over, and as you'll note, this is a time in which the horse has literally left the barn. But unfortunately, stage 5 is the very first time in which most people are being picked up clinically. Stage 6 is severe dementia, where the individual requires a caregiver, specialized care, to be able to now handle their basic as well as instrumental activities of daily living. So what you'll note is that the National Institute of Aging and the Alzheimer's Association, as well as the International Working Group, have worked in a diligent manner to try to help us along the lines of our understanding of the continuum that we should be taking into consideration with Alzheimer's disease. And what you'll note is that right now we are stepping in far too late. If we're initiating treatment in patients at stage 5, that means we've already lost a lot of ground. So where should we be? Well, as we made mention, here's the overall progressive look of what happens. You take a look at cognition, you take a look at day-to-day activities, you take a look at behaviors, or the ABCs, activities of daily living, behavior, cognition, and you'll note that with each staging, as you're walking through, there's going to be additional problems. So it behooves us to help people out a lot sooner. So where are we right now? Well, take a look. This is really interesting. Amyloid changes may precede the onset of dementia by about 20 to 30 years. Because remember, we made mention of those two pathognomonic markers. The gunk that forms in the brain, meaning beta amyloid plaque deposition, and that hyperphosphorylated tau. Well, take a look. 20 to 30 years before symptoms clinically of the individual saying, I'm not remembering what I had for dinner 2 days ago, or what we did a week ago, we're seeing that beta amyloid and the specific numbers thereof are changing in the central nervous system. So it turns out that we can quantify the amount of beta amyloid in the cerebrospinal fluid and that of the brain. And if there's a mismatch, then that gives us an index as to whether there's problems or not. Now take a look at what happens with tau-mediated neuronal injury and dysfunction. This also is preceding any type of brain structure or measured change based on things like magnetic resonance imaging, which is one of our best constructs that we have at the present time for actually taking a look at brain structure right now anatomically, right? And if we were to take a look at that beta amyloid and that total and hyperphosphorylated tau and measure that in the brain and the central nervous system through a lumbar puncture, now we actually have ways of being able to predict who might subsequently, over time, now develop memory problems, and then the subsequent additional manifestations associated with the illness. That then tells us that we have the availability of biomarkers that can help us out a lot. I started out by saying, does everybody develop dementia? The answer to that is no. Different studies have shown that successful cognitive aging is something that can readily be accomplished. And several studies, Christine Yaffe is a terrific friend and a wonderful colleague out of the University of San Francisco, did some really interesting work and took a look at elderly individuals who maintained their cognitive ability. And it turned out that they had several important hallmarks. They weren't smokers. They exercised on a regular basis. They involved themselves socially, and they kept their weight low. And it turned out also that those individuals had had additional benefit or maintained well or had minuscule decline regarding their memory were individuals that could be coupled into a grouping called those individuals with cognitive reserve, meaning that their educational and their literacy levels were above that of the other individuals who were major decliners. So the importance here is you need to use it or lose it. It's an important principle. You know, it turns out that there are heritability factors associated with Alzheimer's disease, and when I have sons or daughters of individuals with Alzheimer's disease ask me, what do? I ask them, well, would you be willing to learn a new language or learn a musical instrument that you've not been able to do up to this point? And typically the response is, no, that's hard. Well, that's exactly the point. You want to challenge your brain in ways in which it's not worked previously. Does that make sense? It does to me. So let's talk about going from pathology to the clinical and the diagnosis of Alzheimer's disease. We know that there are problems that are brewing in the brain. We know that damage is extensive in different brain regions before it becomes manifest clinically. So the big question is, could we potentially diagnose Alzheimer's disease before that cognitive decline becomes so readily noticeable that it's really problematic? Well, it turns out we can. Let's take a look at how we might be able to accomplish this. One instrument that we've had for quite a while, and by the way, we have some impressive tools here at Hoag. It turns out that we actually have a machine that can do an MRI and a PET scan simultaneously. That's kind of nice. Most institutions can't do that, right? An MRI, or magnetic resonance imaging tool, is a tool that helps us peer into the brain and take a look at structures. And generally, if you take a look at the screen here, we're seeing examples of healthy controls versus individuals with Alzheimer's disease. And the individuals with Alzheimer's disease clearly have that enlargement of the sulci, or again, that shrinking that's occurring, and the ventricles get a little bit larger. So the interesting thing is that there's an area called the hippocampus that we could specifically hone in on and look for hippocampal change based on morphology and predict individuals that might subsequently be having additional problems with Alzheimer's disease. But there's even something fancier. It's called a PET scan, Positron Emission Tomography. That's a little bit of a tongue twister, right? It turns out that you can, in a lab, whip up a radioligand, meaning a radionuclide that you can inject into the bloodstream and then have it then be picked up so that it lights up different brain regions. Why do that? Well, it's a really nice way of taking a look at how the brain works. And it's also an interesting way of seeing whether there's enough function that's occurring in different brain regions. And what you'll note in this slide here is that compared to the controls, individuals with Alzheimer's disease have a decrease in the temporoparietal, meaning side and top of, again, their brains bilaterally, because a PET scan basically shows coloration based on a rainbow-hued scale. Hotter colors indicate more function, cooler colors indicate less function, and here we're seeing a great example of the fact that in Alzheimer's disease you start to lose function because you're losing neurons. But it turns out that we've actually been able to upend a PET scan. now we can actually utilize specific radioligands that are amyloid PET scans, meaning we can quantify how much amyloid is in the brain. And if you take a look, on the bottom is the elderly control, and on the top is the individual with Alzheimer's here. And here now we're seeing the exact opposite, where cooler colors indicate there's less amyloid, hotter colors indicate there's more amyloid. That's a problem, right? But guess what? Now we've already addressed the fact that we have ways of being able to pick up on pathology before problems might ensue. So let's take a look at the role of biomarkers in Alzheimer's disease diagnosis right now. It turns out that the National Institute of Aging and the Alzheimer's Association, International Working Group, and the Diagnostic Statistics Manual 5th edition all coincide with the fact that, hey, we should be taking advantage of biomarkers. There's utility associated with this. Let's use them. For the most part, when you take a look at the framework associated with biomarkers, are they an end-all and be-all? Well, not necessarily, but they definitely do help out. And if you have somebody that you suspect might have the very earliest problem with cognition, meaning mild cognitive impairment, and now they actually have more than one biomarker that are testing positive, well, that is somebody with a very high likelihood of actually having the illness, as opposed to the individual that lacks biomarkers and has some of these features. So the interesting thing here is that we note that if you take a look at progression over time, individuals with mild cognitive impairment may actually develop Alzheimer's disease to the tune of about 30% annually. And it turns out that the individuals with biomarkers have a higher rate of progression. That then means that we can actually make that correlate together, which means then that instead of the previous concept that we had of Alzheimer's being a diagnosis of exclusion, now we can actually take a look at utilizing and incorporating biomarkers and now being able to detect this problem a lot sooner than otherwise would have been the case. And what do we have at our disposal? Well, we have lumbar punctures, which can then measure the amount of beta amyloid in the cerebrospinal fluid, as well as what circulates in the brain, and also help us with figuring out how much hyperphosphorylated or total tau are circulating around the cerebrospinal fluid and in the brain. We also talked about PET scans that specifically latch on to beta amyloid. Hopefully, in years to come, we will have a blood test that can be incorporated as a biomarker, but at the present time, we're relegated to this. If we know that the two underlying major high points of Alzheimer's disease are these plaques and these tangles, well, let's use them to our advantage now, because we know 20 to 30 years before an actual diagnosis is made, these are being laid down. So we have a way of incorporating biomarkers that can help us greatly. Let's take a look at some of the challenges, though. It turns out that coverage and payment for these services aren't necessarily absorbed fully. And although it might not necessarily be a scary or daunting issue to have a lumbar puncture, sometimes people are actually reticent, a little scared of having a big needle put into their back. Now, one of the nice things that we have here at Hoag is that we have a phenomenal radiology program, and fluoroscopy-guided LPs are a relatively safe procedure that oftentimes doesn't evoke problems. And the neat thing is being able to incorporate all of these things, because bear in mind, not most clinics can do a lumbar puncture, and not most places have the availability of a PET scan. Guess what? At Hoag, we have a couple. It's kind of nice, because these are very costly instruments, but it's important to be allied with an institution that can help out with the availability of different things. What are some of the clinical implications regarding our understanding of Alzheimer's disease? Well, let's take a look at some hard facts. Alzheimer's disease is the 6th most burdensome disease in the U.S. People oftentimes end up institutionalized because caregivers, and that's oftentimes a loved one, son, daughter, spouse, close friend, associate, are no longer able to procure for the care for the individual. And 1 out of 3 older adults die from Alzheimer's disease or another dementia in the U.S. Caregiving exacts a toll on the individual. It turns out that 83% of the help that patients with Alzheimer's disease get are from family or friends. And by the way, that is generally a labor of love because these are individuals that aren't being compensated for that work that they are doing. That then means that 65% of these individuals end up clinically depressed or clinically anxious. And the cost is astronomical, about $244 billion in unpaid care by loved ones for their loved ones with Alzheimer's disease. That then means that when we take a look at what's the current lay of the land, unfortunately, there are not a ton of specialists that specifically hone in on this field. And unfortunately, primary care physicians have to straddle the fence and deal with 85% of these cases when in reality that might not be their bailiwick, their area of expertise, their area where they feel super comfortable. And oftentimes, the limitations is that the majority of individuals are going to be Medicare recipients, meaning that the overall payment for the clinician is actually going to be lower than would otherwise be the case. So we know that there's a lot of expenditures, a lot of spending, and a lot of considerations from payers regarding this illness, but this is an illness that's growing exponentially. Why? Well, it turns out that this is a neurodegenerative condition that the biggest risk factor is getting older. Back in the day when August D was first diagnosed, people on an average lived to their mid-40s. Now, individuals are expected to live beyond their mid-70s. And what you note based on the Alzheimer's Association facts and figures is what's noted here in this slide, and that is that although we might have about 5 million people diagnosed with Alzheimer's disease, by the year 2050, that's going to be closer to 14 million. And bear in mind, these projections don't include mild cognitive impairment due to Alzheimer's disease. They only include individuals with Alzheimer's disease. And as we stated, the majority of these folks are already at stage 5 or 6. So why is this important? Why are we discussing this? Well, it turns out that there may be reversible or treatable non-Alzheimer's issues that might help out with cognition. Wouldn't you want to know if that's the case? Patients and family members can gain a better understanding of cognitive symptoms if they know about the most common problem that might assail us as we get older. It's important to discuss care planning in a proactive rather than a reactive manner. You don't want somebody all of a sudden to not be able to make decisions and then kind of ask, what would they want? And bear in mind that non-drug, lifestyle-based interventions might be useful for people. Typically, increasing one's hydration, exercising aerobically at least 30 minutes daily, and a Mediterranean-type diet are not bad things to follow for all of us. Legal and financial planning can take place early on, and patients and families can access needed support services. I'll speak more about that in a second because, it turns out that there's an algorithm that's already laid out. Medicare has this annual wellness visit in which clinicians can check whether somebody has cognitive flaws or problems or not. And it turns out that there are various cognitive screening tools that might be used in the clinical setting to detect mild cognitive impairment due to Alzheimer's disease. I want to share with you the fact that, the Orange County Vital Brain Aging Program provides a service whereby those individuals in the community can access what's called the Mild Cognitive Impairment Screen, which is considered a digital biomarker. So this is a test of memory, judgment, language, executive function. Take a look at 5 primary tasks, and basically you do this through the interface of a computer, and it's got a 97% sensitivity for mild cognitive impairment versus normal aging. That's phenomenal. And that's a resource that we have in our backyard. It turns out that Hogue is instrumental in the deployment of that digital tool. Most clinicians typically would reach for an MMSE or a mini COG, a mini screen for taking a look at impairments, the general practitioners, cognitive assessment, or something like the Montreal scale can help along lines of being able to figure out whether people have problems or not. In clinical trials, people like me that do investigational research work incorporate tools that require at least an hour to do, like the clinician's dementia rating scale, ADAS-COG, repeated battery for the assessment of neurological symptoms. I'm not going to bore you with that, but I will say that when we do clinical research trials, we're very thorough about making sure that we've got the right individuals in studies and that we're tracking them appropriately. Now, it turns out the American Academy of Neurology has taken a look at the correlation of age and then the subsequent development of mild cognitive impairment into early Alzheimer's disease and found that with time, people then subsequently convert. So where are we in regards to therapy? Most clinicians can offer a couple of different types of medications. Cholinesterase inhibitors have been around since about 1996. They entail donepezil, rivastigmine, galantamine, and these are medicines that are palliative treatments, meaning that they're not going to change the course of the illness. They may slow down cognitive decline, but they're not going to fix the problem. If the individual reaches a more severe staging, moderate or severe, they can then access an NMDA receptor antagonist called memantine. So memantine works on the glutamatergic pathway, and the cholinesterase inhibitors help with acetylcholine, which is a neurotransmitter that's vital in the brain for creating and retrieving memory. Now, the interesting and exciting thing is that our landscape in treating Alzheimer's disease has changed dramatically. As of this past year, now we actually have a new approved treatment called Aduhelm or Adrikanemab, which has raised a lot of controversy. This is the only treatment that is currently available for mild cognitive impairment due to Alzheimer's disease and can be used in mild Alzheimer's disease. You'll note the other agents are relegated to later stages associated with Alzheimer's disease. So what is aducanumab? You're probably all wondering, and that's probably part of the reason why you tuned in. Aducanumab is a monoclonal antibody. It's directed to the N-terminus of the amyloid beta peptide. Remember that gunky junk that I was speaking about? And we basically get this through a reverse translation in which blood lymphocytes from, remember those healthy elderly individuals who were cognitively normal or had unusually slow cognitive decline that Christine Yaffe described, served as a source of antibody genes for the generation of these recombinant human antibodies. So it's basically a way of recruiting your own immune system to go after this junk. And it turns out that this is only indicated for mild cognitive impairment or early Alzheimer's disease. And the important thing with this is that for those individuals that want this medicine, they have to have specific markers that readily let us know this is somebody that is on way towards getting worse if something is not done. Meaning that a lumbar puncture or an amyloid PET scan have been done and they've confirmed elevated brain amyloid and that specific biomarker issue. In the case of the lumbar puncture, you would see less beta amyloid in the cerebrospinal fluid and more of it in the brain. And there, by the way, are genetic tests like apolipoprotein. The most common variant of apolipoprotein is E3 in Caucasian samples. A protective form would be E2, and a bad one would be E4. And it turns out that if both mom and dad gave you an E4, you have a higher likelihood of developing Alzheimer's disease. But the ApoE4 homozygous allelic representation, that's a mouthful, meaning both mom and dad gave you an E4, those individuals might have a higher likelihood of what is called an amyloid-related imaging abnormality or ARIA. Let's talk about that for a second. So to be able to access Aducanumab or Aduhelm, you need a skilled clinician, you need access to the tools to be able to pick out the biomarkers, and you need to be able to infuse the individual, and you need to be able to track the patient accordingly. Well, it turns out that when the studies were done, and by the way, I am reaching into Jeff Cummings' bag of tricks here. Jeff is a seminal individual in our field and a dear friend and colleague, and he helped out with the development of a white paper that helped us as clinicians be able to figure out what was done in the clinical trials and what's the appropriate use in clinical practice. The importance behind this is that 4 out of 10 individuals might develop one of these amyloid-related imaging abnormalities, which could mean that if your immune system is doing such a good job that it gets rid of the plaque or the buildup, but there was a blood vessel close to that, and now there's a tear, meaning there's some hemorrhaging, or there's swelling, meaning edema. Areas can be either hemorrhagic or edematous in nature. And for the most part, in the clinical trials, they were asymptomatic, but we just don't know. So what we don't want to do is create problems in the brain. So what we do is we take a look at individuals with higher risk, meaning ApoE, homozygous carriers, and we think that once we reach the dose, the right dose that's needed for Aduhelm, meaning 10 milligrams per kilo, that individual should be being tracked with serial magnetic resonance imaging studies, meaning MRIs. And these MRIs need to be done in a specific schedule. And although the experts recommended this, we're actually doing it a little bit different here at Hoag because we have a current determination criteria for the appropriate use of Aduhelm. We actually have nice checks and balances here at Hoag. We have individuals that are specifically looking at fostering the welfare of the patients that run through this particular center to make sure that we are not only a center for excellence, but also have appropriate safety in place. So granted, the individual that is having a baseline MRI is also then going to need follow-up MRIs. And when we take a look at the follow-up MRIs, we're actually doing MRIs right before the doses are being risen or going up with the use of this monoclonal antibody. Well, why do I mention this? Well, I address the fact that within the community, we have the Orange County Vital Brain Program. This is a population-based prevention program that promotes cognitive health through cognitive assessments. And here's the phone numbers. I'd suggest you write this down, 949-764-6288, or look up on the website ocbrain.org. This is helpful because you can either do an in-person memory assessment or we could actually figure out a way of actually being able to get this done for you. Now, another resource that Hoag has is the availability of clinical trials and studies. Why is this important? Well, I've been involved with investigational research work in this space for over 25 years. I used to run the clinical research division at the University of California with the neuropsychiatric program there. And Hoag has the availability of different types of studies. I'll give you an example of a couple. So right now, we're not enrolling for this trial, but we just finished enrollment in a study that was being sponsored by Eli Lilly with a compound that's very similar to Aduhelm. Part of the problem with Aduhelm or Aducanumab is that people get a sense of sticker shock associated with it. It could potentially change the course of the illness, though, and that's the importance associated with it. And what you'll note, based on the next slides that I'll share with you, is that a lot of the therapies that are being worked on right now may be disease-modifying in nature. Aduhelm is truly the first disease-modifying agent since it clearly showed that it could reduce the amount of beta amyloid in the brain, which is something that we can quantify by the term of centiloid. Now, the AHEAD studies are also pretty exciting because this is looking at individuals with no symptoms. but only having the biomarkers that we were speaking about earlier. Now, I'm going to show you one more time the phone number and the website, because the OC Vital Brain program is, I think, a unique program that Hoag fosters and incorporates as something useful for our community here in Orange County. Now, there are, at the present time, 28 different agents in phase 3 trials. 61% of those are disease-modifying therapies. And when you take a look at it, the majority of them are trying to address amyloid, maybe synaptic plasticity and neuroprotection, inflammation, infection, immunity, metabolism, bioenergetics, vasculature, oxidative stress, gut-brain issues. So it's kind of nice stuff that there's a lot of work ongoing. 21% are symptomatic cognitive enhancers, and out of these, you'll know that a fair amount of phase 2 trials are also being done, with the majority of them targeting disease modification. I made mention I'm the director for the Senior Brain Health Program, but I also have had a clinic in Costa Mesa for quite a while, in which we've done a fair amount of investigational research work, and these are some of the studies that we're currently doing there right now at ATP Clinical Research. For example, we were talking about studies that affect the underlying disease process by slowing down progression with synthetic immunoglobulins. And that would be, for example, a study that is sponsored by Elector and specifically targets these interesting areas called triggering receptors that are expressed on myeloid cells. We're also doing a really interesting study, and by the way, the Elector study is delivered just the way that Aduhelm would be delivered right now, and that would be through an intravenous infusion. The Alzheimer study is utilizing a compound called trimiprosate, which binds to soluble amyloid and then doesn't allow it to aggregate in the brain, and as a consequence of that, you don't get that gunky form of junk that would then subsequently choke off different brain regions. Another study that we're doing, the Athera study, is looking at the hepatocyte growth factor and meta-activity, which means that this is a way of enhancing cerebral activity. And this drug has been shown in animal models to enhance neuronal connectivity, to increase cerebral blood flow, to have an anti-inflammatory look, and to enhance NMDA receptor function, meaning glutamate in the brain. And we are also working on the cassava compound, which stabilizes high affinity intersections of A-beta with alpha-7 nicotinic receptors, and observational studies like the Precision Med study, the Biogen study, New Idea study, as well as addressing symptoms. Because once the horse has left the barn, and now the individual is at a more advanced staging of the illness, there really are no therapies that can help out patients. So for example, right now the Acadia 046, the Otsuka 213, the Suvin protocols are all earmarked to help out with behavioral manifestations that individuals subsequently develop as the illness has now grabbed hold fully. And I'll show you a quick snapshot of my clinic, and there's the contact information, 714-277-4472 or atpcr.com, as a resource also for the community. I'd like to just wrap it up by saying this. In the Alzheimer's continuum, early stage Alzheimer's disease is comprised of mild cognitive impairment due to Alzheimer's and mild Alzheimer's disease dementia. The definitions for this illness have evolved to include biomarkers, and they include A-beta and tauopathy to identify patients in this continuum, and soon, hopefully, we'll have a blood marker, because sometimes people get scared off by the thought of a lumbar puncture, which, as I stated, in the hands of a professional isn't necessarily something that one should be concerned or worried about, and things like PET scans, which can be quite costly. The benefits for early disease detection underscore the need for routine cognitive testing. However, there are practical barriers to biomarker assessments. We need to think about these, and we need to overcome it so as to be able to utilize these in routine clinical practice. But in the current lay of the land, participation in a clinical trial is not a bad idea for those individuals that might not necessarily have the resources to be able to avail themselves to additional things that are currently extant. So the importance here is being educated, being aware, knowing about resources, and I'm happy to share that we have a conduit to be able to help out with all of those arenas. I sincerely thank you all for your kind and rapt attention up to this particular point. This is going to be the time in which we can do a little bit of Q&A, and I know that my colleagues here at Hoag will be helping out with parlaying over some questions, and I'll start tackling some of those if you don't mind right now. So the question is, the first one is, if a PET or positron emission tomography or CT scan, a computerized tomography scan, is done from brain to thigh to identify cancer, can the same scan be reviewed to find amyloid plaques and tangles? And the answer to that would be no, because it's an excellent question, but if you were to take a look at the PET-related images of the brain, that would be looking at function. It wouldn't necessarily be looking at as to whether individuals had developed or accumulated amyloid in their brain. For that, you need to utilize a different type of radioligand. So let me share with you. When we're taking a look at function in the brain, we typically would utilize fluorodeoxyglucose, which, again, all the cells in our body utilize oxygen and sugar to function. So fluorodeoxyglucose gets picked up by brain cells and light up the brain in areas, and that's how we can see whether the brain's functioning the way that it should or not. With Amyvid or florbetapir, there's several different radioligands that specifically latch on to beta amyloid. Now we actually have a target that we can use that then subsequently lights up the brain and shows us whether there is junk that shouldn't be there. So thank you for that question. And I believe that there's another question coming right now. This is kind of fun, right, guys? I mean, we get an opportunity of at least being able to interface. I wish it were in person. I always enjoy being able to, communicate with individuals live and in person, but we can always, find a way. Thank you very much. Does taking liquid turmeric help to reduce the risk of Alzheimer's disease? Great questions, right? So here's the interesting thing. Turmeric is found in things like curry, for example, and turmeric has been found to have the effect of what a cholinesterase inhibitor might do, but not quite as much. So will it help? Maybe to some degree. As much as a medication that's currently FDA approved, like donepezil, rivastigmine, galantamine? No. And truth be told also is that, there are certain dietary things that might be helpful, but haven't necessarily panned out in the clinical setting. So for example, lecithin or succinylcholine, which would be precursors of acetylcholine, one might think, wow, those, you chewed up some of that might be good. Well, if it doesn't cross the blood-brain barrier, you're not going to get any benefit out of it, right? What is our first step in evaluation? Taking a baseline test at OC Brain? Phenomenal question. I love that question. Because yes, for those of us that may be concerned, the Orange County Vital Brain Program is a great resource. Again, I think the cost is about $45 for the memory test, the mild cognitive impairment screen. But it's a great way of being able to figure out whether there is a problem or not. And obviously that could help one's doctor, primary care doctor, be able to figure out, man, should we work this up? Should we refer this out? Should we check this out a little bit further? I would say this. The very first thing is, if ever in doubt, check with your doctor. That's why we're here. We're here to serve you. Don't forget that. And that's the important thing, because we stepped into this field to do just that, to be able to answer questions that you might have and help out with clarifying whether there's an issue or not. Could you please clarify if there are possible therapy treatments for patients with moderate or severe Alzheimer's disease, donepezil or memantine? Yes, there are FDA-approved medicines for mild through moderate, all 3 cholinesterase inhibitors, donepezil, rivastigmine, and galantamine. Rivastigmine is found in both a capsule as well as a patch form, by the way. In mild through severe, well, only donepezil and rivastigmine in the patch form. For Parkinson's dementia, only one, rivastigmine. For moderate severe Alzheimer's disease, memantine. Combination of donepezil and memantine is a medicine called Namzaric, indicated for individuals already being treated with donepezil, but about to initiate with memantine. 2 pills in 1, right? But here's the problem. What did we say? Individuals that first get picked up as having Alzheimer's disease are already in stage 5. Some already at stage 6. And there, the problem isn't necessarily cognition. It's now that their behaviors have gotten really bad. They've gotten agitated, they've gotten labile, they've gotten psychotic, meaning that they're having delusions, meaning fixed false beliefs that aren't necessarily accurate. They're having hallucinations. And what do you do for that? Well, there's nothing that's currently FDA approved to treat dementia-related psychosis. In fact, every medicine that's currently out there says very clearly in black bold letters, this could kill the person. But these are medicines that are oftentimes utilized because clinicians don't have a choice. They basically tell the families or loved ones, hey, listen, there's nothing currently FDA approved, but this might mitigate some of those symptoms. That's why we're doing studies like the Acadia 046, the Otsuka 213 study at ATP Clinical Research. So diabetics are advised to reduce, if not minimize, sugar. Sugar is important to the brain function. How is that related to amyloid development? Great question. So sugar is needed. You're absolutely right, but too much sugar is going to be detrimental for you. It turns out that you secrete insulin through your pancreas, and you basically need that to make sure that there's a right regulation of that blood sugar. Unfortunately, some of us are born with diabetes type 1, and some of us develop diabetes type 2. And there definitely have been correlates with vascular risk factors with individuals that are diabetic and or also have high blood pressure. And these vascular risk factors create additional problems for what oftentimes end up being more mixed dementias, right? But also can be implicated with the development of Alzheimer's disease. And that's a really interesting area that's been being looked at for quite some time. So yes, we all need sugar, but no, we don't want too much of it. And that's where it's so important that one be checked out by their doctor, their primary care doctor, family doctor, so as to, if in fact they suffer with diabetes, to have that blood sugar well regulated. And thus the need for medications like metformin or even insulin in the case of those individuals that lack it. How is Alzheimer's disease progression slowed by pharmacological products related to mortality? No. So keep in mind that the only FDA-approved treatments right now up to this point, 3 cholinesterase inhibitors, 1 NMDA receptor antagonist, none of which could reverse the course of the illness. At best, maybe slowing down cognitive decline over time, potentially addressing activities of daily living and behavior. The only medicine right now that may have a disease-modifying profile is Aduhelm or Adrikanemab, but it's only indicated for those individuals. 80% of the individuals in the clinical trials had mild cognitive impairment. 20% had very early Alzheimer's disease. So this is a medicine that needs to be utilized very early on, but may actually arrest some of that progress over time. That's what we're very interested in taking a look at the present time. As the illness has grabbed hold and created more problems, different types of things called dementia-related psychotic symptoms or agitated symptoms may come about. And generally, clinicians will utilize atypical antipsychotics to arrest those symptoms. All of those medicines have a big black box warning that says the use of these medicines in patients with dementia-related psychosis could precipitate their death because of cardiovascular or lower respiratory infectious issues. That is the reason by which we are doing clinical trials, to try to address that with other things that may be safer. And that's the beauty about our field. We continue to explore and look for better, safer options for you. And with that said, I think that I've been cut off. I got yanked out. Thank you all very much for the opportunity to spend some time with you this evening.